MedStar Health's approaches to healthcare. It's an innovative, interactive way to bring you in and talk to you here on Facebook Live. So we're glad you're joining us. My name is Megan Pringle. I am your host this evening. I'm with WBAL, and we have a lot of smart people here to talk to us about what is going on with our hearts. So we definitely want to hear from you. If you're watching on Facebook Live, give us a like, a little thumbs up, send your questions in, and your comments as well. It's nice hearing from you, and we will try to get to those as the next half hour moves along. Where we are right now is MedStar Union Memorial, their full-service hospital, and during the next 30 minutes, we are going to discuss the latest in innovations, advancement available to repair structural conditions of the heart. So again, let us know. We want to hear from you, and we're going to get to our panel of doctors, and we'll start with them and then get to all of our questions that we have. So we'll start with Dr. Michael Fiocco. You are a cardiologist here, and you're going to talk about the structure of the heart and the valves and what that means, and what exactly is structural heart disease?
So structural heart disease in its simplest form is any defect that occurs in the heart that's not related to the coronary arteries. So that includes valvular disease, defects of the wall between the upper chambers of the heart, defects of the wall between the lower chambers of the heart. And this terminology has been used for some time, but probably the first structural heart therapy was in the 50s when doctors were brave enough to put a balloon into the pulmonary artery in little children who had pulmonary artery narrowing. So that was sort of the advent of structural heart therapy.
Have you seen a lot of changes as far as heart surgery goes?
Oh, sure. I've been here for over 20 years just in this hospital. And so it changes not only in the techniques as far as less invasive techniques, the equipment gets better and better all the time. The effects of what we do, open heart surgery is a big trauma. It's a tremendous, it's what we call a punch in the nose. It's really shocking to the patient, but even that has become less and less over time. The patients tolerate it much better now than they ever did, and we're able to operate on older patients, sicker patients.
And you're the chief of open heart surgery, so I'm sure that you have seen it all and really get an opportunity to get excited about the advancements that they do here at MedStar.
Sure, and you know what we've also seen is our, there used to be in all of medicine, particularly in the cardiac portion of medicine and surgery, almost a competition between the surgeons and the cardiologists, and now we have to work together. We don't have a choice. We have to go over these patients together. That's the best way to care for them, and we make decisions as a group more than independently, more so than ever before.
We just got a question, if you guys are comfortable taking it. Anybody who wants to can. But we had Catherine write in, and she was asking about her grafts. She had them 3, and they had failed. Is there anything you can do about that? I mean, I know you need more information than giving medical advice on Facebook.
Well, let me just start with graft failure. It's a known complication of bypass surgery. It's not very common. It's even less common to see 3 out of 4 grafts fail. But in order to describe or decide what therapy, you really have to determine why did they fail. Is it because you're sewing to coronary arteries that are so diseased that going back and doing another operation isn't going to help you? Is it a bad graft conduit, as we call it? Is that the problem? And sometimes it's just people's inflammatory reaction. Again, they hate this trauma to their body, and some people react in a way that the grafts close down. But there's a lot more that Dr. Wong can do in the cath lab with his associates to open these grafts up now and open up the native arteries. So rarely do they have to go back for an operation.
All right, thank you. I'm sure Catherine appreciates that. We like hearing the questions in the comments, so certainly bring them in. Now we want to send it over to Dr. Momina Mastor. You kind of described when we were talking earlier that you are almost the photographer of the heart. Explain a little bit about what you do, your title, and how this all fits with everything in terms of the structure of the heart.
So just like Dr. Fiocco was mentioning, we actually, I'm a non-invasive cardiologist. I see patients and I do echocardiograms, which are pictures of the heart. And over the years, things have evolved, and now what I get to do more and more is look at structural heart, and if there are defects in the valves, or if there are holes in the heart, or the valve is tight, or it's leaking, I get to look at it with a special test, which is called a transesophageal echo, which is basically a tube which has a camera at its tip, and then I make the patient swallow it, and then I can look at the heart from behind. And then we actually sort of do it in real time. So if Dr. Wong is working on the patient, say from the groin, and he's trying to fix something, and I know that we're going to talk about it further, I get to be there and actually be the picture part, So when I'm describing it to my patients, I actually say, these are my plumbers, they are fixing stuff, and I'm the photographer. So yes, so like we were discussing earlier, medicine has evolved and technology has evolved, and we have better equipment and we have better pictures. So we can actually really get literally inside the heart and get a very close, up close and personal look, as I tell my patients, and then make a diagnosis.
And I imagine that's an area where really the technology has really evolved, as well as the collaboration.
It has. We are. We have some great machines which are available now, so they can really get us some good pictures, and that helps in that team approach. So now, previously, I remember when I started working here 15 years ago, he was doing his stuff independently, maybe Dr. Wong was doing his stuff, but now we get to collaborate, and which I think is really good for patient care, because we all come together and you have all different aspects, and then we can treat the patient.
As far as the heart goes, and before we get to that, I wanted to say that poll just popped up, and I guess people could weigh in, but you guys are the doctors, you're the experts. Somebody wanted to know about congenital heart disease, if all of it is hereditary. Is that right? Is that, it just disappeared, but
we'll have structural heart disease, yes. Congenital.
Yes.
That is 100% false.
False. Gotcha. All right, good. This is why you clear it up, and I guess we get this information.
Some people are born with an abnormal valve, and over time it deteriorates. And some people are born with a normal valve that can deteriorate due to infection or hypertension or heart attack. And so, there are congenital issues that are structural, and there's a lot of acquired issues that are structural too.
Can you explain the 4 valves and how that, how would you explain it to a patient if you were talking to them about it?
The most common valves that we deal with are the mitral, which is the inflow valve to the left ventricle, the main pumping chamber, and the aortic valve, which is the outflow. So the mitral valve opens, blood comes in, the heart contracts, the mitral valve closes, so blood can't go backwards. And then the blood goes forward through the aortic valve, and once it pumps, and the aortic valve closes, so it can't go backwards. So that's a standard valve in any plumbing circuit. It's a series of valves, just like in your home. The tricuspid valve, it's much less likely to require surgery. There are defects with it at times, but it really is a valve that does not have a lot of its own disease, a lot of its own problems other than infectious problems. The pulmonary valve is really a congenital problem in small children. We rarely see it in the adult population.
I bet you guys, just as far as the true or false comes in, there are so many myths out there when it comes to the heart, and so many ideas of what it means to take care of it and how to treat it. So it's good to have you guys clear it up. Dr. Wong, I wanted to talk to you. Dr. Wong is the chief of the cardiac cath lab here, and you gave us a tour of this place earlier, which was great. Can you, explain replacing a valve without opening the chest? Because we were just talking about the valves, and I think that's another one of those things that people think happens every time there is something involved with the heart.
The aortic valve is one of the most important valves, and like Dr. Fiocco said, it is a valve that opens and closes with every beat of the heart to allow blood to go to the rest of the body. As we get older, there's a certain percentage of us that develop calcium on this valve, and it becomes very restricted. The normal area of this valve is 4 to 5 squared centimeters, but it can be a pinhole and less than 1 squared centimeter and calcified. When that happens, Dr. Mastor, myself, Dr. Fiocco, as well as other members of the heart team meet, and we discuss these patients to decide the best care for them. And traditionally, the only way to fix this has been open heart surgery. But in 2012, the FDA approved something called TAVR, that's TAVR, or transcatheter aortic valve replacement. And that is actually a way to replace this aortic valve by putting a catheter in the femoral artery and going up across the aortic valve and deploying a new valve that's mounted on a stent. And the whole procedure is done with the patient asleep, but usually not even with the breathing tube in, and takes under an hour. It's a much faster recovery, and it's something that patients have benefited from since 2012. This video is one of the 2 commercially approved valves, and this is the balloon expandable valve. And you can see in the animation that we're going across this tight valve, and what we do is we actually, when we rapidly pace the heart, we expand this balloon, and mounted on this balloon is a stent, a very large stent, and inside this stent is the aortic valve. And as soon as we deflate the balloon, the stent stays behind and the patient has a normal functioning aortic valve. People always ask, what do you do with the old one? And as a matter of fact, we use the calcium from the old valve as an anchor to hold on to the new one. And it is amazing and remarkable. And again, this procedure really has revolutionized this field. This is the other commercially approved valve, and this is a self-expanding valve. There are unique advantages for each particular patient as to whether they need a balloon expandable or a self-expanding valve. But this is why it's so important to have a team approach when we first evaluate the patients, what's right for them. This is definitely not one size fits all. This is a video of one of the representatives loading this valve. Since it's self-expanding and made of nitinol, the frame, it's a metal that has memory. We actually crimp it, and that's what it looks like when it's in its crimped state. It's really remarkable. It's about the size of a number 2 pencil. And then this is a picture of what it looks like after it's already been deployed. That, believe it or not, is what the groin looks like after we're done the procedure. And we also measure their blood pressure through the wrist, and that's a comfortable transradial band on. A far cry from the days of old where you had no choice but to have your chest cracked open. I'll say one thing is that a lot of patients will say, well, doc, why don't you do this on everyone? And right now the FDA has approved TAVR in patients that are not operable candidates, patients that are high risk for open heart surgery, patients that are intermediate risk for open heart surgery, and we're evaluating this technology to make sure it's safe in patients who are low risk or standard risk for open heart surgery.
There's so many different components that go into the heart, you know, in terms of preventative, and then, you know, when you're treating something that it's an emergency. So it's interesting to hear about that sort of thing and basically see the difference between those 2 valves. So I know you're heading up a research project in Baltimore. Can you talk about that a little bit?
One of my roles, or one of the hats I wear, is to run the clinical research program in Baltimore for the MedStar North system. And that encompasses research throughout the whole cardiovascular division. But what's pertinent to this webcast is really the structural heart studies. And I told you about the 2 commercially available valves, but we've also been evaluating the next generation, the valves that are actually, believe it or not, already available in Europe, that we now are undergoing the pivotal trials in the United States to make sure they're approved and we have access to those for our patients. We're also looking at valves, and we'll be entering these trials soon. We're looking at the other valve that Dr. Fiocco talked about, the mitral valve. And the mitral valve is a much more complex valve, much more difficult valve to treat, and we're going to be participating in different technologies that can help with leaky mitral valves as well.
So we have a Facebook question from Lynn. She said, what causes structural heart conditions? Can it be caused by lifestyle issues, like with traditional heart disease? And anybody who wants to grab that can.
Well, uncontrolled blood pressure, for instance, like we mentioned earlier, because structural heart, like we mentioned, can involve the valves, and it's regular wear and tear. And if your pressure is high, you know, those things can affect the mitral valve, for instance. You know, it can cause it to become leaky, and then the heart dilates, and then suddenly you have a leaky valve. So those lifestyle issues, I think, would definitely could, you know, make a structural heart worse. I mean, there's some things that you're born with, but then there's natural wear and tear, which is made worse by, you know, some of these lifestyle choices that patients make.
Sure.
Although we don't include coronary artery disease in the structural heart realm, coronary artery disease can lead to mitral valve regurgitation. You know, as your heart becomes injured by blocked arteries, your valve can leak, and it's one of the most common problems we see with the mitral valve is ischemic or poor blood flow causing mitral regurgitation. So for the person who asked the question, yes, heart-healthy lifestyle is really important, and even though your coronaries aren't part of this structural talk, that's the life you should be living.
I imagine that means the things that we always hear from our doctors, and that's a healthy diet and exercise, no smoking. Is there anything new that you tell patients to take care of their heart?
No, I think those are we always talk about the traditional risk factors that we can help modify, making sure your blood pressure is under control, your cholesterol, if you have diabetes, make sure that's under control. But when you take a look back at it, it's pretty remarkable, the human body as a machine. And if you think of the heart as a pump or a machine, the fact that we have patients in their 80s and 90s, what machine do you know functions that are 80 years old and 90 years old? Right? And the body does. So in addition to being born, like Dr. MedStar said, with certain congenital abnormalities and having coronary disease and having heart attacks, there's also just a natural wear and tear. And these valves were not designed to last 100 years. And certainly not when patients may not have been treating their bodies so well.
So much of today's complex cardiac treatment options, they're now being done in a lab. So what exactly is a Watchman? It sounds like a cool TV show, but.
Pertains to the most common arrhythmia in Americans, which is atrial fibrillation. Atrial fibrillation is projected to affect 20 million Americans, and this is actually an arrhythmia that causes the top chambers of the heart not to contract well, and it fibrillates, and it actually looks like a bag of worms. So because they don't contract well, there is something called the left atrial appendage, which is an outpouching of one of those chambers. And when the heart doesn't contract well, blood can pool in there and form blood clots. The danger with that is that if one of these blood clots breaks off and goes to the brain, you can have a stroke. So many Americans that have atrial fibrillation are on Coumadin or one of these newer agents that don't require you to have your blood checked, but they have to be on very powerful blood thinners. The Watchman device, and I think we have a video of this Watchman device, is actually a device that was approved by the FDA 2 years ago, which is actually a mechanical device that's shaped like a little mushroom. And here you see what it looks like when it's deployed. This looks like a little mushroom, and it fits inside of the appendage, closing off that area and reducing the risk of a stroke. So this animation is a procedure where the patients are sedated, and we go up through the groin. Dr. MedStar guides us with her echo to cross the intraatrial septum very safely to go from the right side of the heart to the left. We pass our catheter up, and the appendage, you'll see, is that outpouching on the bottom. We enter it very safely. They labeled it looking like a windsock. We labeled it with a pigtail. We enter it with a pigtail catheter, advance our sheath, achieve the proper depth. And again, it's because of Dr. MedStar's expertise, her planning with the echo to tell us exact size we need. We pick the proper size of this, and we deploy it inside that appendage. And you can see after it's deployed in there, we do a little tug to make sure that it's actually secure, and we release it. And in 45 days, the body covers it with its own tissue and excludes that area where blood clots form. So this procedure reduces where 95% of blood clots occur in patients with atrial fibrillation, which is the appendage. So in 6 months' time after this procedure, patients come off of their Coumadin and they're just on an aspirin. And that has been the real benefit to this procedure, is that we're able to take these high-risk patients that have an arrhythmia, that have to be on blood thinners, and usually they're very elderly, they can't tolerate these blood thinners, and now we can offer them a mechanical device that'll allow them to come off of their blood thinners.
You mentioned Dr. MedStar sort of guiding you through that. What is that like from your perspective?
Well, it's actually quite challenging but very exciting, because you can help the patients. And during this procedure, for instance, it's very rewarding to be there. I've seen those patients beforehand. They get referred to me or to my heart team, and then I evaluate the risk of the procedure versus the risk of being on a blood thinner for life. Then we have to size that part of the heart appendage, which he mentioned. So I get to meet them then, and then actually I get to be there during the procedure. So it takes about 45 minutes. They go with their catheter. We guide them. And then once it's done, if you remember the last image, we have to look for the fit and make sure there's no leak. and then they come back again actually to me after 45 days, and I repeat the transesophageal echo again and make sure that it's securely in place, and then that's when they come off the Coumadin. So it is very rewarding because, you know, I've typically, if somebody that we did today, I met them say back in April, we planned the procedure, did it today, and then I'll see them in 2 months and then they'll be off Coumadin. So that journey, I think, is, you know, it's and the fact that I'm involved directly in it, it's very rewarding.
Is there a downside to an intense blood thinner? Is that how you described it? You know, is that hard on a patient?
It is. I mean, a lot of elderly patients can't tolerate that. They have bleeding from gastrointestinal bleeding, what we call GI bleeding. Patients can fall, and if they bump their head, they could have a bleed into their head or their brain. So it is a big problem being on blood thinners, not just the nuisance bleeding of bruising easily, but really life-threatening bleeding, and that's what we're trying to mitigate.
The collaboration between all the different places, is that something that's changed over the years? Is that something that took a while to get used to, I guess, using, you know, different experts for you know, one common organ? That's kind of remarkable.
I think Dr. Fiocco put it perfectly, which is that in the past there was definitely a very siloed approach to medicine, which is cardiac surgeons were in the operating room doing cardiac surgery. Cardiologists were doing procedures in the cath lab or seeing patients in the office like Dr. Mastor. But now, truly, this is a team approach. And the heart team is a concept that is not a very old concept. It's only a few years old. But it's one that we've embraced here. And really, we evaluate these patients as a team to make sure we're delivering the right approach. And the one other thing I'll say is Dr. Mastor is being very kind. When we do these procedures, we are completely relying on her and her echo to guide us. And we are going where she's telling us to go as far as crossing the septum. We are going with the depth and making sure that the device is placed, and she has the ultimate say if it looks good or not. And so she's the one directing us, and then we follow her instructions carefully to make sure it's deployed properly, and then again has the job of evaluating it immediately, which is very stressful, but then also following these patients to make sure they have a good long-term outcome.
A comment just came up on Facebook that you were fantastic, incredible, and then somebody else said the two of you took care of a Facebook viewer who's watching right now, said they took care of my brother. So it's got to be nice to see those things. Dr. Mastor, one thing I wanted to ask you, because you mentioned earlier birth defects and commonly heard problems are holes in the heart. Can you sort of explain, I guess, what that means? And they occur at birth, but that's got to be a scary thing for a parent to hear.
It is, and it depends on the kind of hole that we're talking about. There's something called a PFO, which is a patent foramen ovale. So it's in the upper chamber of the heart, and you have two upper chambers and two lower chambers. And actually, 20 to 25% of normal people have it. So it's nothing, to worry about. Now, when we deal with those patients, it's typically in the setting of a stroke. And then we may end up closing it again, through the leg. But the other kind of holes that we can get are VSDs, and again, those you're born with. And sometimes, as a consequence of heart disease, like Dr. Fiocco was mentioning, if you have, say, a blockage and you have a big heart attack, you can get a hole then also. But so there, yes, you can have holes, but all holes don't need to be treated. So I mean that I think is an important message, because people do freak out if somebody tells them, oh, you have a hole, and so every hole does not need to be treated. And that's why if you're told that, then you need to see a cardiologist, or come to our heart team, and we can evaluate and tell you if it's important or it's relevant or not.
If you guys wouldn't mind taking another question, someone named David wrote in, I'm 69 years old with a fib. I also have a TIA that was the cause of the AFib that was put on, is it Pedexia?
Pradaxa.
See, clearly not a doctor. I survived cardiac arrest in 2012. Do you think the Watchman would be good for me to have?
So obviously we need a little bit more information, but the Watchman procedure has been approved in patients that can tolerate blood thinners but are at increased risk of bleeding. They also, we put their risk factors into a risk score calculator. It's called the CHAD VAS score. And that's beyond the scope of this webcast, but we want to make sure that they have enough of a risk for having a stroke. Clearly this gentleman has already had a mini stroke, so that puts him at very high risk. And then we would have to see him in our clinic to make sure that he is at high risk to be on the Pradaxa, and if that's the case, he most likely would be a candidate.
Christine just wrote in, she said, these doctors are the best. Do you run into that a lot when you're at the grocery store and somebody said, you saved my brother? I mean, it is nice reading those comments, and it's got to make your job pretty remarkable.
It does. I mean, it makes you feel good, but you know, most of what we do is make somebody's life better. You know, it's rare that we are actually saving somebody's life, and it's more that we're improving their life. And so you can't dwell on all that. There's another case coming, and you have to dwell on that. You can't sit there and say, "Boy, we really were great. We were great."
Sure.
You know, you have to say thank you very much, and you move on to the next one. It's you know, but we have a good understanding of, you know, exactly, you know, what we're doing, who we're helping, and, you know, but it's always nice to get that back. And it tends to go to the doctor, so I'm always encouraging my patients. I said, how about the nurses? How about the
Nurses are
techs
amazing.
on that floor? How about everybody else up there that took care of you? Please send a letter to Mr. Chambers and outline all those people. So we see more and more of that now, where they remember everybody's name and they make sure that they thank everybody.
For those of you who are watching on Facebook, Mr. Chambers is Brad Chambers, and he is the head here at MedStar. So definitely, if you loved your nurse, let them know, and your doctor as well. One last thing, I guess, before we go, anything that excites you guys right now? I know you have the research project, and technology is always changing, but is there one thing that you look at and you think, like, this is just such a remarkable field because it's always evolving?
Well, for me, it's, you know, we've had a remarkable, robust program in these transcatheter valves. From its infancy, where the cases were very challenging, to almost routine. And, you know, now I think we're going to start heading in that direction for the mitral valves, and so that's something that's exciting for me, that, you know, if we can have a program similar to the aortic program in the mitral realm, I think that's going to be great for us and the hospital and our patients.
All right.
And I think it's really seeing these technologies evolve so rapidly. This whole field of structural heart was essentially non-existent when I was going through my training 15 years ago. And to watch how it's exploded, we in this institution have done over 500 transcatheter aortic valve replacement procedures in a short amount of time. So like Dr. Fiocco said, when we see the next generation of these valves for the mitral valve, that's very exciting for us.
Can you go a little bit more into what the mitral clip is at all?
Sure. The mitral clip is actually a device that is actually placed by putting a catheter through the groin. We go across from the right to the left side of the heart, and we actually place a clip on the two leaflets of the mitral valve. And what that does is it reduces the amount of leakiness of that valve. So the mitral clip procedure we're going to be starting this summer, and this is a procedure that is very well tolerated by our patients that otherwise would not have any surgical options because they're too sick.
All right. Well, fantastic. This has certainly been very interesting. I want to bring Brad Chambers in, and pretty remarkable stuff that goes on at your hospital.
Every day. I think our physician said it the best. We're changing lives here, and that's how we get into healthcare. And we couldn't do it without the wonderful physicians here, but really all of the staff. Healthcare is a team effort, and we've got wonderful team members here. So thank you. Really, I want to thank everyone for tuning in tonight. I specifically want to thank Megan Pringle and all of our team at WBAL for being our media partner tonight for these wonderful webcasts. We appreciate all the comments that came in tonight. Really, to all of our viewers watching us live right now, thank you. Thank you for your comments about our physician panel. Really, we are very proud of our heart program here at MedStar Union Memorial Hospital, and it's really about giving back to the community and giving back to our patients. So on behalf of everyone here at MedStar, I wish everybody a wonderful evening. Thank you.